I'm going to call the meeting to order. Please rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Good evening, everyone. Dee, please.
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Epen.
Present.
Director Danielson.
Okay, I just want to make a short announcement. Nancy Farber had to be called away due to a fire that is burning in Palomares Canyon, off Niles Canyon in Palomares, and her home is in the general vicinity, and so she had to get back there to see to her husband and to her pets, and as I was coming in about 10 minutes ago, I heard on the radio that the fire was about 30% contained, and so hopefully that her property and possessions and loved ones will escape harm's way. So she cannot be here tonight for that reason. Okay. Moving on, we're going to move into our education session. Kimberly?
Thank you, Mr. Wallace. I'd like to introduce to you Dr. Stephen Zahner. I know he's presented in the past, but I will give a little overview of his history. Dr. Stephen Zahner is board certified in family medicine and completed a fellowship in primary care sports medicine at Rush Presbyterian St. Luke's Medical Center in Chicago. Dr. Zahner is part of the Washington Township Medical Foundation as a primary care and sports medicine physician. His former positions include head team physician for Arizona State University and volunteer physician at the U.S. Olympic Training Center in Colorado Springs. Dr. Zahner's interest in concussion studies began in 2010 with baseline testing and giving concussion seminars to the general public. Over the last 3 years, he has worked closely with Stanford neurosurgeon Dr. Jamid Gahar, utilizing eye tracking technology to aid in the diagnosis of concussion subtypes and corresponding management of this increasingly common brain injury. Dr. Zahner also serves as the concussion program director of the Tri-Valley and Golden State Elite Youth Ice Hockey Program for Northern California, as well as the medical consultant for the concussion committee of the California Amateur Hockey Association. Dr. Zahner is a key member of the Washington sports medicine team and serves as a concussion expert. He is here tonight to present the findings from a concussion study that was done in partnership with Indiana University on football players at a local high school here in Fremont.
Well, thank you, Kimberly, for that very nice introduction, and thank you all for coming. And I see we have our athletic trainers from a few of our athletic trainers from our high schools here tonight, which is great because I know they're busy and everybody's busy, especially with the fires. Again, this is quite a time we're going through. I think N95 is the word of the day. Getting a mask like that is important. But regarding concussion and what we'll be talking about tonight, there's definitely a lot of that to go around as well. I mean, we've seen fire. Well, concussion is definitely a field that has kept me busy. What I want to do first, though, before we go into it, is give you a quick overview of our program in sports medicine, just a couple of the things that we do. We were very successful this last year, and with the success and with the approval of the board and our administration and backing, we were able to get 3 more athletic trainers, so now we have a total of 6 schools. And that's been a fantastic addition to our program. That's enabled us now, as you can see by these visits here, that we've increased or basically doubled our visits in the training rooms. And if you can imagine, these kids, many of them very busy with their athletics and homework, don't have time to even see their own parents. So if they do have a concussion or some issue, the athletic trainer is the go-to person. So we're very pleased to have that footprint in our community now, and very happy that we have these athletic trainers putting in the time that they do to help these kids. apologize about the slide here. It looks like there's a little overlap. Basically, what we're saying here is, this is the game coverage. So last year we've had 17 games we covered, and this year we had 29. And that's quite a few games, let me tell you. We were spreading that out among 6 physicians, and they're very nice in donating their time. That would be Dr. Russell Nord, Dr. Mike Golden, Dr. William Moore, who's from Kaiser, myself, Dr. Halimi from our ER, and I think I may have forgotten one more person, but they're all very helpful. The other thing I wanted to mention that we are involved with as of last year was research. And been very fortunate to have partnered with Indiana University in an upcoming star, I would say, in the concussion field in his own right, Dr. Kei Kawada. And it was a happenstance circumstance where I was looking to find other people who were using the eye tracking technology or were familiar with that kind of approach to concussion. And Dr. Kawada was, and we started talking, and one thing led to another, and I asked him rather boldly, I said, would you like to collaborate here in California? And he thought about it, and one thing led to another, and I'll be presenting the study that we did today. Out of this one body of work that we did with 15 athletes, we're probably going to end up with 5 papers. Our first paper was accepted for publication. It will be coming out in December in the Journal of American Medical Association Ophthalmology, and that is going to be using, it'll be having to deal with oculomotor tracking using something called near-point convergence. I won't have time to go into that today. But the buzzword in all of this is what is called subconcussion. So I know that a lot of us have been taught that, well, how many concussions have you had? How many times has your head been hit? What have you? But we're now beginning with great gravity and understanding to gather up the evidence that the number of hits and the size of the blows all add up. And so we're really excited about this research. This research study that we did at Irvington High is basically a pilot to a much larger study that I'll talk about at the end of my talk today, give you an idea of what we have upcoming. So the one I'll be presenting today, it's in peer review right now in Frontiers in Neurology, and it is called the Association of Increased Serum 100B or 100 Beta. I'm not going to try to talk over your heads. I really want to make this user-friendly. And so what I'll do is I'll flash through the slides and I'll give you an overview and understanding of what the study was about. So basically, we took on a high school, and we decided to see if we could get the entire team to be recruited. There was about 40 kids. And as soon as we mentioned that there was going to be blood draw, I think that about knocked the number down to about 15 to 20 right off the bat. So the blood draw was a big scare. And of course, I can imagine, and at first I thought we were going to have a lot of trouble with the coaches because of performance and all that. And there was all those issues that we had. But I would say that in the end, we ended up with a number, working with our statistician here at our hospital, Lamaya Sheikh, was a powerful enough number that we could draw some conclusions. Otherwise, it would not have been a valid study. So just an overview. So what is subconcussion? When we talk about concussion in any sport, a lot of times we always talk about blows to the head. So it's not just a blow to the head. A concussion or a subconcussive force is one that's transmitted to the head through the body, neck, or even directly to the head. So you don't have to hit your head to have a subconcussive force delivered. So you can imagine there's a lot of that going on in a football game, and you can see the comparison of these G-forces. When you go out on Fleet Week and you watch the Blue Angels fly by and you see some of these rolls they do, that's about 9 Gs. And just crashing your car into a wall at about 30 miles an hour, I think the distance is about 30 yards, is going to give you 60 Gs. And as you'll see, in the study that we did, we used a mouthguard technology that enabled us to measure impact, not in the helmet, but it was in the mouthguard, an accelerometer. And the forces that we saw on our phones and through the device's telemetry was just astounding, up to 150 plus. These kids are sustaining these forces. So these forces can range, and there can be single concussive impacts, multiple concussive impacts. This study dealt with repetitive. So one important thing to help you understand the study, is that there are two kinds of forces we talk about in concussion. And there's linear acceleration, which is a force going directly at you. But as you can imagine, once that force is delivered, there's going to be a shift. There's going to be what we call a rotational force. So there's very often two forces going on. And if you can think about when you're on a playground and you're spinning around on one of those playground, what are they, merry-go-rounds? It's been so long, I forgot. You know how those centripetal forces can be so great. It's the same type of thing with the head. So if the body's getting hit, where the athlete got hit in the chest and their head snapped, or they got hit in the head, and you've seen some of those hits on TV, they can be quite severe, and that rotational force is the one that just gives added magnitude. So there's a little picture of linear acceleration, the brain moving in a linear direction, the traditional what we call coup contra coup movement, and then rotational acceleration. And again, I want to emphasize that first picture here. Let me see if my pointer is working. And how am I doing on time, by the way? Good, okay. A lot of us are still in that thinking that the concussion is an external injury, one where the brain is, being injured almost by the skull itself. While that can happen, what we're talking about in concussion now, and it's the exciting part, is we're beginning to understand that there's actually a shearing of the axons deep within the brain, underneath certain structures that are acting as stress risers. When we get that happening, a lot of effects occur, and one of them, if you can imagine, I'd say 80% of our sensory input is visual or visual related. So that's why we start looking at eye tracking using a device like the iSync or near point convergence as being very important tools that can give us hints as to perhaps there may have been an injury. This is just a quick picture of the mouth guard. It's unbelievable technology. It's incredible. So in this little piece right here is the accelerometer with a battery. Each of these cost about $200. And so again, Dr. Kawada forked out about $15,000 out of his own pocket for the entire study, which I thought was great. Of course, we also gave our resources in terms of man hours and time and commitment and support from Kimberly and Nancy and the Institutional Review Board. We had a lot of support from our hospital as well, but financially he put out a lot. And so these devices are still not considered the gold standard. I mean, they're pretty darn good, so there's still some controversy about them, but they're a heck of a lot better than the ones that are mounted on top. There's a West Virginia Tech is probably got the gold standard helmet, and that has 6 accelerometers embedded inside the helmet. And these helmets themselves are thousands of dollars, so you can imagine that's almost a prohibitively expensive venture. But by the same token, at least we have something we can get a gander or an idea of what is happening on these kids' brains at the ground level. So again, this is just showing you a little diagram of what peak linear acceleration would be. You get hit, and then you get the rotational acceleration. This is the other technologies that are available out there. This is the one at Virginia Tech with the accelerometers inside the helmet. Many of the others. This is an interesting idea where you might have, somebody has to wear a helmet like in soccer. And again, they're all not very good. I think the best one would be something in that helmet like they use at West Virginia Tech over the mouth guard. Again, a very busy slide. The basic take home on this slide is that there is shearing going on and that means a stretching of the axons. And then there's all sorts of cells supporting this. Well, the blood biomarker that we used in this study is called S100B, and it is in the astrocyte, which is a cell that supports and nourishes the neuron. So if the neuron is stretched far enough and enough damage occurs, you will get release of that enzyme, and that's what we were looking for in monitoring, to seeing if this was high enough to be consistent enough to be valid for a conclusion. And we were looking to see if that would correlate with our study of the eye tracking. So again, this is just showing you S100B. I'm not going to get too much more into it, but it is being used in Europe at certain levels. They're finding that if it's high enough, you can then make a determination that a CT scan might be indicated. So in other words, they've done enough study with this biomarker to say we have enough evidence to support the fact that when this blood level is at a certain amount, that would warrant getting a CAT scan or an MRI. So you can imagine how that would be extremely important and useful in an emergency room. But there's many other biomarkers out there. So S100B happens to be one of the more studied. Dr. Kawada originally did a study, a hallmark study at Temple University. Very, very busy slide, but it was a similar type of study, and he did it in college football players. So the exciting part about our study, this was the first time this was done in high school players. This is a big deal. You can imagine, when you're 18 and you're in college, you can sign your own life away. We had to get a lot more involved with the parents and getting support from the community on this, including the district. So this is an overview and showing you what we did. We chose 6 games to take our data from, and we decided at the beginning of the season we needed a baseline, so we did baseline measurements of everything, including the near point convergence and the S100B. And then during the games, we got clever on this. We thought, okay, well, the games are on Fridays. The coaches aren't going to be happy, neither with the players, if we did the blood draw before the game, like an hour or two. So we thought, well, maybe we could lure the kids in with some lunch, and that's what we did. So we would get them sandwiches or food, and they would come into the training room at the high school, and then we would harpoon them. We would get our blood and move on. The amount of blood we used was very small. It was about 4 milliliters, so it wasn't enough to really cause any physiologic problems. I think we may have had 1 or 2 cases where maybe it was bleeding a little bit too much. I think once we had a kid pass out, and I think that same athlete, I think he withdrew from the study. We started with 17, and we ended up with 15 in the study. So we then, at the end of the season, also did some measurements because we wanted to make sure that everything that we had found in the beginning, did it come back to baseline, or had it changed just as a matter of course of the entire season. So we have 6 data points during the season. We're looking before and after the games to see if there's a physiologic change, and then we're looking at the entire season to see if there's a change overall. So we did also use a heart rate monitor. Again, I won't get into too much of that, but what we were trying to also determine is, you can imagine these kids are running around, and there might be some that are standing on the sidelines, not playing as much. So is that kid standing on the sidelines who may have got 150 G-force, is his S100B, is that going to be as high as a kid that maybe is running around and not getting hit as much? So we needed to get an idea of how much effort and how much work they were doing. And so we used the heart rate monitor along with some really sophisticated equations. I mean, the team that Dr. Kawada has of statisticians and grad students is really remarkable. So they did quite a bit of incredible number crunching. So we've got the head impact measurements, the linear and rotational acceleration components by the vector mouthguard, and then our blood test. We would draw these. Right after the game, we'd run back to the Nakamura Clinic where I was working at the time and spin them down and pipette them off We had a pre-med student help us out, and she got into med school. I'm sure it wasn't just because of the study, but we wrote her a very nice letter of recommendation, as you can imagine. And she was very instrumental in helping us draw this very important blood. And then what I would do is I would take it that night, put it in a very special FedEx box that it was like a $30 box in and of itself that had ice in it, and we'd ship it off to Indiana. And then Dr. Kawada would pick it up. So there was quite a bit of logistics in this, a lot of late Friday nights, but it was well worth it. So as I said, we ended up with 15. We started with 17. That's the average age. Independent variables, of course, we're talking about pre and post game. It did end up being 5 games. As you can imagine, in any study, and Carmen, our head athletic trainer over there, will attest to this, it seemed like on any day, something was always going wrong, right? It was just, there's always something, and it was made it a little bit exciting, but at the same time, a lot to handle. So one of the games, I did not realize, I did not think ahead that the game was going to be done at Moreau, and that they weren't going to be as open to us drawing blood on site. And they did not want us touching any kids, even though they were our kids, so to speak, on their site. So we could not we drew the blood that morning, we had it ready, and we could not use the data or do any data afterwards other than just eye tracking. So we had to throw out that data. So we would have had 6, but we had 5. So again, because the numbers were so small, you'll see we decided, one of the statisticians came up with a great idea. Is there enough data that we could actually lump it into a low versus high impact group? So you'll see that data as we present it as well. Dependent variables, of course, would be the blood study. And then we have the head impact, what are called kinematics, the peak linear acceleration and rotational acceleration. Again, a busy slide. Again, giving you the flow of the study. We started off with 17, 2 withdrew. There's the mouth guard being used in all the practices, through all the games, collecting data. That's a fantastic device. It really is. I mean, it's just constantly sending information to a laptop, and we just have to download it later on. So that made it easy. But the logistics of fitting the mouth guard and the kids chewing on the mouth guard. You just chewed on a $200 mouth guard. I mean, it's. I don't think we had to actually replace any, did we, Carmen? No, I think she gave them enough of the fear of God that they wouldn't do that. The $200 out of your own pocket, I think, would have scared anybody off. Anyway. What else can I say about this? So we had there were some practices involved. And this is the demographics. So years of football experience. One of the most important parts of this study, of course, would be that the kids did not have any previous concussion, or at least within the last year. That was very important for us to make sure. And then here are the positions. And this is a really interesting statistic that if you read the literature or see that this is averaging, each kid was averaging about 600 hits, at least across these 5 games. 600 hits, that's not 600 hits per game, but over those games. And when we're talking about PLA, that's linear acceleration, that's a total of almost 12,000 Gs. And then here's where you really understand centripetal force, right? The linear or the rotational acceleration of over a million Gs. That's a tremendous amount of force that these kids' brains are experiencing. So what we did is this slide is basically showing you that the S100B that we drew before and after the games, it went up. I mean, it went up. There was a couple times where it didn't. Obviously, that's going to happen in any of your data sets. But what we did find that there was a very significant correlation between head impact statistically and S100B. The linear acceleration, a p-value of 0.002. And again, if you remember from statistics, 0.05 is, most studies will be considered statistically significant. So we're talking about 0.002 p-value, and then the rotational acceleration was the most significant at 0.005. So I thought that was very impressive. Again, another busy slide. What this is trying to get across to you is to show you that when we split these groups into two groups, the high and low impact, we actually saw the data start to coalesce and make some sense. So what we found is that we had kids who obviously were in higher impact, had higher S100B changes, and the ones with lower had lower. Interesting fact, none of the kids had a concussion. In our study, none of the kids had a concussion. That would have been interesting too. So again, remember, this is a pilot study, so when we do this with larger numbers, there may be some interesting conclusions drawing from that. That's that in a nutshell. These are the people involved. That's Dr. Kawada. He's not that young, but he does look quite young. And these are his grad students. It's funny, when I presented this in Ohio last fall, I mean, this is how fast social media travels. I mean, I had just gotten off the podium and someone walked up to me and said that this guy in New York already had heard about it from somebody and was just excited that it was being presented. So it was just kind of funny how the word gets out. Here's Carmen and her football team. And then here's our pre-med student, Sierra, that got into to med school. So this leaves us with what we have for the future. Dr. Kawada and I have continued, we work really well together. It's great. He's a great leader and a great, he's very imaginative and fortunate that we can work together. He understands my passion and understanding of concussion. So he's decided he'd like to partner with us on a multi-center or multi-site subconcussion study. So as we speak right now, the NIH study is being written, and the purpose of the study is to look at subconcussive head impacts over time, and we're talking through a high school student's career. So it's going to be 3 to 4 years, and we're going to be looking at cognitive and sensory impairments. In specific, we're going to be using the blood biomarkers. We're going to use ocular motor function, near point convergence, and in Indiana, they're going to use diffuse tensor imaging, which is becoming of a gold standard for looking at concussion with more rigor. As you know, a standard CAT scan or MRI scanner will not pick up concussion. So that's one of the big takeaways from one of the more recent studies that came out, that really sending your kids to get to the ER, you're really not going to see anything on the CT scan. I realize that we're all thinking you're ruling out a subdural hematoma or an intracranial hemorrhage of some kind, but these diffuse tensor imaging and MR spectroscopy are very much on the horizon. They'll be very exciting because we'll now begin to see what areas of the brain can be involved, and we can correlate that perhaps with the expression, what happened to the person, what part of their body is affected, whether it's memory or balance or vision. So we're talking about in 4 to 5 high schools in Indiana and 2 to 3 high schools in California. So this is going to be a pretty big study. And it will definitely keep me very busy. I'm not going to be running around to 3 high schools, but I'm going to have to oversee several people working at these local high schools. So that's it in a nutshell. If there's any questions, I'll be happy to entertain them right now. But again, I want to thank Nancy and Kimberly in particular for their support. This has been a lot of hard work and a lot of times last minute stuff. Can you get me something really fast legally or what have you? And they would do it. And I think going forward, the sports medicine program here has a lot of promise, and we need your support to do more with these athletes, because right now we're just a small little group. I'm just in a little clinic in Center Medical Group right now, and we've just got a few things going on, but this could really develop into quite a program here. And so with that, I'm I'll leave it to any questions, and thank you very much.
Thank you, Dr. Zahner. Any questions with anybody? Go ahead, Jacob.
I have one question. I mean, now that you have a marker for head trauma, as 100 beta, I think it's released by astrocytes. Do you plan to extend the study to other sports like soccer, where apparently head traumas are very underreported?
Well, right. I mean, the question is, are we going to perhaps expand the study to other sports where you would not think of concussion necessarily being as prominent, but we do know, like for instance in soccer, that's pretty much the definition of subconcussion right there, heading the ball numbers of times. It would be very interesting to do that, but doing a study with football, I think, is going to be the first step. But Dr. Kawada has done another study where he fired a soccer ball at volunteers who allowed them to have their head hit, and they got it passed by the IRB, and they were looking at the biomarkers there to see what happened there. So, and we laugh about it now, right? Getting hit in the head with a soccer ball, but we all have done it, and we still think it's okay. But it is a force that we're dealing with. I just met with a patient of mine as a football coach, and he was just talking to me today that their sport is devastated. There's no longer freshman football. No longer freshman football. Now they're down 40%. And my statistics say that in California it's down 23%. So he's telling me it's down 40% at this one high school. So people are recognizing quite fast that the sport, football has very serious dangers. And I'm actually writing something right now for this ophthalmology report that we have, trying to summarize and let people know why we feel this is so important. And if you think about it, in baseball, we have a pitch count for the elbow and the shoulder, right? Yeah. And then we'll take the pitcher out at 100 throws, and oh my God, the arm. Yeah. But we don't have anything like that for the brain. Yeah. To me, that's where I would like to get us to the point where we could, with either through the work with the blood biomarker and the use of eye tracking, perhaps the trainers on the sidelines could very easily just say, let's use this stick that we use, the ruler, to measure near point convergence, and maybe a number of hits combined with the accelerometer could determine, near point convergence, a number of G-forces. You know what? You're on the threshold based on our data that you're either going to have a concussion or you're having too much of what we call a burden, and we need to sit you out for a week. That's not going to go well with the coaches, but it's certainly going to make the sport safer. Yeah. I hope that was a adequate answer for that long-winded response of mine.
Yeah, thanks.
Any other questions?
No. Thank you, Dr. Zahner. It's very important work that you're doing. Thank you. Okay, we are now going to move on to consideration of the minutes of the October 10th, 22nd, and 24th meeting. May I have a motion for that?
Mr. President, I move for approval of the minutes of October 10th, 22nd, and 24th.
Do I have a second?
Second.
Okay, thank you. Dee?
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Danielson?
Okay, are there any oral communications this evening?
There are not.
Okay, thank you. Before Dr. Tsoi presents the credentialing action items, I want to acknowledge that we've received a letter from Mr. Bill Gallagher of the California Nurses Association approximately 2 weeks ago. We are directing the staff to create a response to Mr. Gallagher's letter in connection with any legal advice you may deem necessary, and then we will consider the action once you have done that. All right, Dr. Tsoi.
Hey, good evening. So here are the proposed prudential action items for tonight. We have 3 new appointments. First is Jacqueline Dow, a nurse practitioner. Yesha Patel, DO of Family Medicine. And Nancy Stoll, Family Medicine, MD. Temporary privileges approved for Doctors Dow and Patel. I'm sorry, Nurse Practitioner Dow and Dr. Patel. Under reappointments for 2-year, we have Michael Bastash, Radiation Oncology, Irene Beisner, OBGYN, Ashwani Bindal, Medicine, Asol Dalgashiva, Pediatrics, Kissing Se, Surgery, Nancy Hua, Internal Medicine, Soham Javari, Internal Medicine, Connie Lee, Internal Medicine, Brian Lipson, Medicine, Allergy, Immunology, Diane Martin, Infectious Disease, Kevin Morrissey, Emergency Medicine, Shaista Shah, Internal Medicine, Rajesh Suri, Cardiology, Stephen Watt, DDS, Maxillofacial Surgery, Helen Wong, Internal Medicine Hospitalist, Richard Wright, Otolaryngology, Stanley Yu, Gastroenterology. 1-year reappointments include the following: Dr. Rajiv Ahuja, Internal Medicine; Huan Chan Chen, Interventional Cardiology; David Chang, Medicine, Hematology, Oncology; William Clausen, Pain Management; John Yako, Pathology; Marco Pavesi, Internal Medicine; and Mary Lee Schuhart, Pain Management. There are no conditional reappointments. Under non-reappointments deemed to have resigned, we have Norma Paragas, Pediatrics. Transfer and staff category include the following: Jennifer Areola, CCP, Perfusionist; Jamala Friday, Pediatrics, Active to Ambulatory; Narayana Gunda, Internal Medicine, Active, Provisional Active to Active; David Hawley, Radiation Oncology, Provisional Courtesy to Courtesy; Daniel Kennedy, Critical Care Medicine, Provisional Active to Active; Chiramathi Raghu Subramanian, Internal Medicine Hospitalist, Provisional Active to Active; and Helen Wong, Medicine, Provisional Active to Ambulatory. Completion of proctoring and advancement staff category, we have David Hawley, Radiation Oncology, Provisional Courtesy to Courtesy. Under completion of proctoring prior to eligibility for advancement in staff category, we have Kaprit Chahal, Dr. Wei Fan, Dr. Sanya Jurani, Dr. Gurinder Singh, and Nurse Practitioner Taihan Gran. Extension of proctorship and provisional category is extended to Dr. Tang Li. New privilege requests include Sunil Sood for critical care as a pediatric hospitalist. Deleting privilege requests include Dr. David Chang, Dr. Kissing Si, Dr. Marco Pavesi, and Dr. Sohail Sood. Under resignations, we have PA Karen Garn, MD Katerina Guzman, Dr. Lisa Lam, Dr. Christina Lee, Dr. Robert McCabe, and Dr. Byron Wilson. That's the end of my report. Thank you.
Thank you, Dr. Stoy. Can I have a motion for approval of the credentialing action items?
So moved.
Thank you.
Second.
Thank you. Dee?
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eapen?
Aye.
Director Danielson?
Thank you. Jenny, good evening.
Good evening. Greetings from the volunteers. October, busy month as normal, and even beginning of November. We do have a disaster response team that we put together with 29 key, strong volunteers, and so I thought we need to do a drill and see if we called them, who could actually come. And so we found out that of the 29, 17 would be able to report within 20 to 30 minutes, so that was 59%. And so that was kind of good to know, and we always learn something when we do these drills. Yesterday, this week, Monday, Tuesday, was our annual holiday gift show for the gift shop. And so I just wanted to thank the hospital and the staff for turning out and supporting that. A lot of people from the community came. I heard one woman yesterday coming to visit, and she saw the flyer left over on the counter. She, "Oh, I missed it." I said, "There's still plenty of stuff to buy. Go visit." But anyway, it was a great event, and we appreciate everybody's support. Speaking of support, coming up, our $5 jewelry sale, December 3rd, 4th, and 5th, in these very rooms. A lot will be happening, so we look forward to that. And the last thing I wanted to share was we welcomed a new Assistant Director of Volunteer Services. Her name is Evangeline, and yesterday, Move Day, was her second day. The big news is she came back today with a smile on her face. So she stayed 12 hours yesterday supporting the volunteers in the lobby, helping them and encouraging them and staffing herself, and I love her already. So this is a great hire, and we're excited to see all the great things that she can accomplish as she supports the volunteers. So thank you.
Okay, any questions? Thank you, Jeannie. Thank you. Okay, Dr. Tsoi?
So under the medical staff report, we're happy to say we have 350 active members with a grand total of 596 members now on staff.
Thank you. Okay, Kimberly, we're going to move to...
The hospital calendar, yes.
Past health promotions and outreach events. On Saturday, October 13th, Briar Elementary School in Fremont held its annual health fair for students, teachers, and parents. Washington Hospital staff provided health information, including the importance of proper hand hygiene. More than 200 people attended, and 58 people visited the information booth. On Thursday, October 18th, Washington Hospital hosted the 10th anniversary of the Think Pink Breast Health Awareness event. The event featured a health fair and presentations by Dr. William Degoni, General Surgeon and Medical Director of the Women's Center, Dr. Bogdan Evtimia, Hematologist-Oncologist, Medical Co-Director of the UCSF Washington Cancer Center and Medical Co-Director of the Washington Cancer Genetics Program, Julie Aragon, Washington Wellness Center Tai Chi Instructor, and Lori Roffelson, Registered Dietitian. Dr. Victoria Leapart, Gynecologist, emceed the event. 317 people attended. On Wednesday, October 24th and Thursday, October 25th, Washington Sports Medicine hosted sports physical clinics for local high school students. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Medical Director Dr. Russell Nord, along with other providers from the Washington Township Medical Foundation, provided the examinations. Athletes also received orthopedic screenings by certified athletic trainers. The event also included a health fair highlighting the benefits of pre- and post-exercise and nutrition. Each athlete paid $20, which will be donated to the schools for sports medicine supplies. 135 students received sports physicals. Also, on Wednesday, October 24th, Dr. Diane Martin, infectious disease specialist, Dr. Bruce Lynn, vascular and interventional radiologist, and Dr. Bogdan Evtimia presented the link between hepatitis B and liver cancer, prevention and treatment. At this seminar, participants learned the critical importance of hepatitis prevention and treatment. They also learned the signs and symptoms of liver cancer and how it is diagnosed and treated. 17 people attended. On Friday, October 26th, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the Elementary Special Olympics soccer tournament at Maloney Elementary School in Fremont. 333 student athletes participated. On Saturday, October 27th, Washington Hospital and the Taylor McAdam Bell Neurosciences Institute hosted the Advances in Neurosciences 9th Bay Area Symposium. In addition to a vendor fair, more than 145 attendees experienced presentations by internationally recognized experts on topics including management of opioid dependency, minimally invasive spine procedures, brain mapping technology, concussion diagnosis and treatment, latest research on Alzheimer's disease, and robotics used in spine surgery. The program coordinators were Dr. Sandeep Kunwar, neurosurgeon, Dr. David Larson, radiation oncologist, and Dr. Moses Tagioff, neurosurgeon. A special award was presented by Chief Executive Officer Nancy Farber and Dr. Kunwar to Dr. Tagioff in recognition of his contribution to the neuroscience program at Washington Hospital. On Friday, November 2nd, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the secondary Special Olympic soccer tournament at American High School in Fremont. 321 student athletes participated. On Thursday, November 8th, as part of the Caregiver Series, J.B. Goodyear, Spiritual Care Coordinator, and Father Jeff Finley, Palliative Care Coordinator, presented Caring for Someone with Dementia or Other Medical-Related Memory Loss. 23 people attended. On Saturday, November 10th, Washington Hospital hosted the annual Diabetes Awareness Health Fair. The event featured a health fair including blood glucose, cholesterol, and blood pressure screenings. Dr. Amir Dashka, podiatrist, also provided diabetic foot exams. Dr. Archana Bindra, endocrinologist, presented diabetes maintenance care, and registered dietitians Makaria Meyer, Lori Roffelson, and Mary Sun presented Diabetes Diet, Creating a Healthy Meal Plan. Dr. Prasad Kata, endocrinologist, emceed the event. 113 people attended. 107 had their blood pressure measured. 69 glucose and cholesterol screenings were provided, and 43 people received a diabetic foot exam. On Tuesday, November 13th, J.B. Goodyear presented Getting Through the Holidays When You Are Grieving. 21 people attended. Upcoming health promotions and community outreach events. On Thursday, November 15th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present Keeping Your Brain Healthy. On Wednesday, November 28th, from 6 to 8 p.m., at the Washington Township Medical Foundation Newark Clinic Conference Room, Dr. Victoria Leapart will present How to Sleep Your Way to Better Health. On Friday, November 30th, from 1 to 3 p.m., Lori Roffelson will provide a healthy holiday cooking demonstration. At this seminar, participants will learn how to prepare delicious, healthier alternatives to the traditional favorites to enjoy during the holidays. On Thursday, December 6th, from 7 to 8 p.m., as part of the Diabetes Matters program, Ana Mazet, RD, will present Latino Cuisine. This presentation will explore modifying traditional recipes to make them healthier without losing their distinctive flavors. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. October's featured topic was Building for the Future, which highlighted the new Morris Hyman Critical Care Pavilion, plus articles on how the new pavilion improves patient care and healthcare accessibility. The Washington Hospital Healthcare Foundation Report. The Washington Hospital Healthcare Foundation hosted the 32nd Annual Top Hat Gala on October 13th in the tent at Washington West. The evening began with a hosted cocktail reception, followed by dinner and dancing. 715 attendees joined us to raise funds for the new emergency department and intensive care unit in the Morris Hyman Critical Care Pavilion. The evening raised $190,000 and included a salute to first responders who support Washington Hospital's emergency and critical care physicians and clinical staff. Helen Kennedy, the president of the foundation, said, "The evening was a great success, and I am so grateful to all the sponsors and donors. My thanks go to this year's gala co-chairs, Dr. Carmen Akawili, Marcia Badella, and Dr. Kadir Halimi." Join us on Friday, November 24th at 6 p.m. for the Niles Festival of Lights Parade. The Washington Hospital Healthcare Foundation is this year's presenting sponsor and will be featured on one of the parade floats. The Washington Hospital Healthcare Foundation is preparing for the annual Trees of Angels celebration, which raises funds for hospice and palliative care. Please mark your calendar and be sure to join us at one or more of the following holiday tree lighting events. Bernardin Family McDonald's at the corner of I-680 and Mission Boulevard on Monday, November 26th at 6 p.m. Washington West on Thursday, November 29th at 5:30 p.m. Newark City Hall on Monday, December 3rd at 6:30 p.m. and Union City City Hall on Wednesday, December 5th at 6 p.m. For more information about these events or to inquire about sponsoring Trees of Angels, please call the Foundation at 510-818-7350. Washington Hospital Employee Association, WIA. WIA concluded the 2018 Drive for Warmth clothing drive on Monday, November 5th. 10 barrels of warm clothing items and blankets were collected and delivered to the Tri-City volunteers to be distributed throughout the community. Washington on Wheels WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic WOW is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. The intent is to discover undiagnosed conditions before they become serious and to treat chronic conditions before they turn into life-threatening emergencies. Some screenings are free and other services are provided on a sliding scale from free to low cost. During the month of October, WOW served community members at the Fremont Resource Center, Fremont Senior Center, and the TCV Food Bank and Thrift Store in Fremont, Ruggieri Senior Center and Tropics Mobile Home Park in Union City, and the Viola Blythe Community Services Center in Newark. WOW also provided occupational health services including influenza vaccines at California Brazing, a manufacturing company focused on heating and thermal management for the development of metal and ceramic parts. Fremont Bank, a retail and commercial bank. Lee's Imperial Welding, a producer of structural metals. Materion Brush, Incorporated, a supplier of alloy metals. Mizuho OSI, a medical device company specializing in surgical tables. Amaran Scientific, a leading supplier of machine safeguarding products. These companies are located in Fremont, Newark, Union City, Hayward, and Livermore. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of October was 464. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment page was October's most viewed web page with 41,141 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of October, Washington Hospital's cable channel 78, InHealth, captured new programming including 2 health and wellness programs titled Taking Charge of Your Health and The Link Between Hepatitis B and Liver Cancer, and a Diabetes Matters program called Healthy Food Across Cultures, Filipino Foods. In addition, InHealth aired health and wellness programs titled Peripheral Vascular Disease, What You Need to Know, a caregiver series program on securing care preferences through advanced healthcare directives, and the October Board of Directors meeting. Additional events and announcements. In 2016, Washington Hospital installed a Veterans Wall on the first floor of the Washington West Building to honor members of the Washington Hospital family who served in the U.S. Armed Forces. Each year, the Veterans Wall is updated to include the names of new employees or physicians who served in the military. This year, we added the following names to the recognition wall. Bryn Jesse, Army E-4 Specialist. Sterling Jones, Marines, E3 Lance Corporal. Michael Levitt, Marines, E3 Lance Corporal. Brian Treff, Marines, E4 Corporal. Craig Euler, Navy E4 Petty Officer 3rd Class. Alexander Watson, Army E4 Corporal. We thank all members of our military branches for their service. Awards and recognitions. On Saturday, October 20th, Washington Hospital hosted the annual Employee Recognition Reception. The event honored 203 Washington Hospital Healthcare System employees. Combined, these employees have been part of the hospital family for an impressive 3,386 years. That evening, the hospital celebrated a rare and extraordinary anniversary of a special 50-year employee, PBX operator Nancy Tondag. Not many hospitals have celebrated such a momentous occasion. Nancy has been the life force for the past 50 years that callers hear any hour of any day. She has been committed to Washington Hospital, whether calling an overhead code in an emergent situation or connecting a family member to a loved one in the hospital, and always dedicated to providing excellent service. On October 23rd, Healthgrades announced that Washington Hospital is again the recipient of its America's 100 Best Hospitals for Joint Replacement Award for the 8th consecutive year. The hospital also received America's 100 Best Hospitals for Orthopedic Surgery Award for the 2nd consecutive year. These awards are the result of Healthgrades' evaluation of almost 4,500 hospitals' performance nationwide in 32 of the most common inpatient procedures and conditions. These awards demonstrate how clinical performance differs dramatically between hospitals nationally, regionally, and at the local level, and the impact that the variation has on health outcomes. Washington Hospital is the only hospital in the Bay Area to be named America's 100 Best Hospital for Joint Replacement for 8 consecutive years. Washington Hospital Stroke Program received the American Heart Association, American Stroke Association's Get With the Guidelines Stroke Gold Plus Quality Achievement Award. The award recognizes the hospital's commitment to ensuring stroke patients receive the most appropriate treatment according to nationally recognized research-based guidelines based on the latest scientific evidence. Washington Hospital earned the award by meeting specific quality achievement measures for the diagnosis and treatment of stroke patients at a set level for a designated period. These measures include evaluation of the proper use of medications and other stroke treatments aligned with the most up-to-date evidence-based guidelines with the goal of speeding recovery and reducing death and disability for stroke patients. In addition, Washington Hospital received the association's Target Stroke Elite Plus Award. To qualify for this recognition, hospitals must meet quality measures developed to reduce the time between the patient's arrival at the hospital and treatment with the clotbuster tissue plasminogen activator, or TPA, the only drug approved by the U.S. Food and Drug Administration to treat ischemic stroke. Washington Hospital Healthcare System received an award from the American College of Surgeons National Surgical Quality Improvement Program for achieving meritorious status with regard to surgical outcomes. This award considers quality scores in both the all cases and the high-risk categories. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
Kimberly, we're going to move to the lane report.
Well, before we do that, we have a couple. We're going to do the. We're going to have the Move Day update, and I wanted to just present to the board and let everybody know that as of yesterday, after years of planning and all of the time and the construction, we opened the Morris Hyman Critical Care Pavilion. So we're very excited about that. I want to tell you a little bit about the schedule for that day. That day began at 7 a.m., and we closed down our existing emergency department, and we opened the new one in the pavilion. And then at 8 a.m., we started moving our critical care patients one at a time sequentially over to the new pavilion. After that, we then moved our medical oncology patients, and then we moved our intermediate care patients, and then lastly we did our telemetry. So over the period of the whole day, we moved around 57 We moved 57 patients, and then we ended about 550 last evening. So we're very excited. I know we've been talking to our patients and our staff and everybody, and they're very excited to be in the new building. And our patients were very much enjoying the larger rooms, the single rooms, and all of the light and the air. So, as I said, really all the time that's gone into the training and all the mock moves that we did have really paid off, because we did a very, everybody moved safely and efficiently over to the Morris Hyman Critical Care Pavilion. So very happy about that and happy to announce it. And you can see here that a number of pictures that show us the move that happened yesterday. And then lastly, we just want to, there's a video that we want to show you too from Bennett Hall. So just want to again thank all of the staff and the physicians who have taken the time to really to train and to work to safely ensure that all of our patients were transferred over. And we had different transport teams that worked that were made up of caregivers and physicians and appropriate staff to move everybody. So thank you. We're very excited now to have patients in the pavilion. So before we move on to Lean, though, I think we want to do Employee of the Month. So we can do that.
Okay.
I am pleased to announce that Hai Ran Yang, RN, is Application Analyst, Information Services, and she is our November Employee of the Month. Just to tell you a little bit about her. Young and brave is the description Hai Ran's mother used to describe her when, at the age of 24, she announced she was moving from South Korea to the United States. Armed with a bachelor's degree in nursing, Hai Ran arrived in Sacramento, California, feeling confident she would land a job as a bedside nurse, and she did. In 2008, in search of better weather and a new opportunity, Hai Ran joined the nursing staff of Washington Hospital. She worked as a critical care nurse until 2011, when she was asked to lend her expertise to the EPIC project. Her analytic skills combined with clinical background create a valuable resource, and in 2013, she became a permanent member of the Information Services team. Vicki Otting, Director of Inpatient Clinical Application, says that anything HIRAN is asked to do will be done efficiently, accurately, ahead of schedule, and often with added user enhancements. She is responsible for several projects, including our EPIC infection control module, sepsis identification, and managing the logic for EPIC pain alerts. Together with her team, she has recently been involved with new device integration into EPIC documentation for the Morris Hyman Critical Care Pavilion. HIRAN loves the challenge of her work, comparing it to putting together pieces of a puzzle to create tools for physicians and nurses to provide better care for our patients. She says, "I believe all Washington hospital employees are part of the patient-first ethic, whether they directly interact with patients or not. I am happy to be part of that." Vicki Otting notes, "We are lucky to have such an intelligent, competent member of our team and someone who is a pleasure to work with." HIRAN and her husband, David, both had left families to live in the Bay Area, and while they sometimes miss the family support, they enjoy taking vacations to visit their childhood homes. Every summer they travel to South Korea, and every winter they travel to Hawaii. Thank you.
Thank you. Okay.
All right, the lien report. I'm going to ask Chris Brown, one of the directors in the KPO office, to produce the lien report this evening, and we have some couple of certificates and pins to present.
All right, so this is actually, as a director in the Kaizen Promotion Office, this is a particular presentation I really look forward to because we're recognizing several individuals who, in addition to their professional responsibilities, have completed the rigorous training and requirements to become Lean Leader certified. But before I do that, I want to give you a little bit of background. Washington Hospital began its journey or its implementation of the Toyota management system in October of 2011, which I think is about 4 years before we broke ground on the Morris Hyman Critical Care Pavilion. So we've been at it for a while. The journey really is designed to help us become the high quality, low cost provider and of choice, which is something that is critical to our mission. The purpose of certification is to promote and the purpose of certification, first of all, you want to promote and lead Kaizen activities in the institution. And the other purpose is so that we can train others in lean methodology. So in a sense, we're using kind of a train the trainer approach when we do this. And the goal really is to make lean the philosophy and methodology for all improvement activities. So what's required for lean certification training? Lean certification is a 12 to 18 month process. It requires proficiency in lean concepts and tools, and candidates are evaluated for successful performance with each step of the process. In terms of the requirements for lean certification, there are 8 full days of classroom education. Part of that, the requirements include participation in 1 value stream mapping workshop, participation in 1 Kaizen workshop, and in addition, they need to act as a team lead in a Kaizen workshop and act as a workshop lead in a Kaizen workshop. So to date, there have been 39 that have been certified, and that includes 37 managers and 2 physicians. So tonight we are adding 4, and I'm going to invite each one of them up individually. The first one to come up will be David Hain. Do you want to?
Mr. Wallace is going to come up.
Okay. Good. Thank you. Thanks so much. Thank you. Just
Speak into the microphone here. The next will be Raju Chera. Sam Avila.
Sam? Thank you. Congratulations. Thank you.
And finally, Vicky Otting.
Congratulations.
All right, and congratulations to all the recipients.
Okay.
Next, we have the construction report. I think it's going to be relatively short this evening. Ed Fan will be doing the construction report.
Okay, so yes, we're winding down our construction. As you can see, really our only thing left is the back loading dock. And this gives you a view that this is the new loading dock section, and then part of the project is to update this section as well, and make it similar in appearance, and then we'll have roll-down doors. We haven't been able to totally secure this loading dock since we built it, and so these will all finish with doors that'll roll down and lock, and gives us quite a bit of extra capacity from what we did have. And it also breaks it up into two sides of clean and dirty. So this side will have not only the refuse coming out, cardboard, recycling, things like that. So this is a significant improvement over what we've had. Really out of this project, one thing that's probably noteworthy is that I think every department that has been affected by this has seen a major upgrade in their facilities, whether it's obviously something like critical care or PBX and security. It's all been, significant steps better than what they have had historically. This is another part of this, which is a big bioswale. As you walk around the campus now, we have multiples of these around. This has to be put in this end of the campus. This is right off the loading dock is back over here. And so we have to have water from this whole area washed off into a bioswale, which is in between the main building and CJR. And as you can see, we opened up the employee entrance part of the building a couple of weeks ago. And this is the east entrance, or the part of the building that faces Bartway. And it's actually very convenient, walkable entry from the garage. So that I think has worked out pretty well. So yeah, we're pretty much done. I can't imagine we're going to have many more updates here, because we've got pretty minor things to get completed, and we'll be totally done in Rodolph and Slettenoff site by January. So yeah, the move date occurred yesterday, and we're pretty well wrapping it up. Okay.
Congratulations, Ed.
Thank you.
Thank you.
Nancy did want to recognize Ed Fayen's leadership over this project and the many hours and years that he and his team have put into the successful completion of the project.
Indeed. Thank you. Okay.
Next, we're moving on to the quality report. Mary Bowron, our Chief of Quality and Resource Management.
Good evening. Tonight I'll be giving you an update on our quarterly report for quality for quarter ending 6/18. But prior to getting into that, I wanted to talk about one of the awards that we recently received, which I think is a great reflection of the quality that we have here at Washington. You saw on the calendar, they spoke about this briefly, about the fact that the American College of Surgeons has given us a meritorious award for our participation in the NSQIP database, which is a database that we abstract from every day related to surgical procedures that we do in the hospital. We submit them on a national basis and participate with about 586 other hospitals across the nation. And we were chosen as one of 86 hospitals to be given this award based on the fact that when they looked at the outcome of our cases over the year of January 1st, 2017 through December 31st, 2017, they recognized that when we have complicated cases of patients and still have to perform surgery on them, we have actually had better outcomes with these patients as we follow them for 30 days than the national average. These are patients who have to be on ventilators for 48 hours after surgery, patients who have renal failure, patients who develop problems with urinary tract infections, those sort of things. So it's a real great measure of success. We sent a quality coordinator into our national conference this year, and she was approached by a few of the other hospitals there asking for some of our practices and what's best practice that we have found that gave us these outcomes for patients. And we're sharing this with the surgical medical staff committee, and they can continue to use it as a learning opportunity. We have many other aspects of the database that we're going to pursue further this year also. But moving into our quarter ending September 2018 for quality, our core measures, we continue to do well on what the interventions that we're putting in place to prevent patients from developing blood clots while they're in the hospital. We look at the critical care setting and in the med-surg setting. This particular core measure is 100% electronic abstraction from the record. This is not a sample. These are all of the patients who needed interventions to prevent blood clot developments, and we've done well on that with 93% of the patients outside of ICU and 100% getting these interventions in a timely fashion. The process of doing this is still fairly new with CMS, and so they have not given us a benchmark on that. I feel confident that we'll exceed the benchmarks. We've been doing well for the past 4 quarters. And moving into stroke, continuing to stay close and above our benchmarks on a national and state level. Discharge medications, these are the medications that the patients are given prior to discharge, and we have to give them education on how to use them, what are some warning signs with bad side effects that they need to contact their physician on. We were able to get that for just a little under 98%. This is actually a reflection of 2 patients, and we followed up with them after discharge and were able to get that education to them, but this is measured by discharge time. Stroke education on signs and symptoms of stroke complications. All of the patients received that prior to discharge, and they were all assessed for rehabilitation. Moving into our infection prevention indicators, central line associated bloodstream infections, continuing to see some up and down movement with this. These patients in this last quarter for 9/18, this is actually a reflection of 4 individual patients, 2 of which were in med-surg and 2 of which were in critical care. Both of these patients had quite a bit of comorbidities, long length of stays, and the actual catheter was in their bloodstream for an extended period of time. So those kind of risk factors that lead it to be higher risk to develop a central line bloodstream infection. However, we still have to take it seriously to say, what is there anything that we could have done to maintain these 4 lines better than we did? So the process we use for that is our team, Dr. Akawili, Dr. Martin, the infection prevention staff and nursing kind of get together and really drill down and look at these cases and see if we can find any root cause analysis. And we'll be sharing that with the Infection Prevention Committee and the medical staff to see what changes we may need to make. As you know, MRSA is something that we still have to report on a national level, and it's we've had now, of course, 6 quarters where we have not had a patient who came into the hospital and developed a bloodstream infection with MRSA within 48 hours of being admitted. far below the benchmark for the national average. Same with vancomycin-resistant enterococci infections. Again, very difficult to treat with an antibiotic. We did have one patient who had this, and it was the patient who unfortunately had it in their central line bloodstream infection, long-term patient in critical care. This, again, will also go to that same team and be reviewed to see if there's any lessons learned from the practice of that patient. That did put us slightly above the benchmark, but we continue to have had 4 quarters out of the last 6 quarters that we were under benchmark. C. diff has continued for now what we could state as a sustained lower C. diff rate, which is a big accomplishment for us in the hospital because it has continued to go on a downward trend, and now we are not just at the average, we actually have been better than what we expect to have for a C. diff rate in a hospital of our type and size, less than expected by the CDC. This was 6 cases of patients that developed C. diff within 72 hours of being admitted. Again, any case that you identify C. diff in the patient out on their 3rd day of being here, we do not look at the clinical case. It's called lab ID, meaning that if they test positive for C. diff on the 3rd day, the national standard is that they consider that hospital associated. So one of the things that we've continued to focus on, and we will, is our antimicrobial stewardship, our EVS cleaning, and our infection control practices. During the move yesterday, one of the things that we took very seriously was the cleaning of equipment and transport, to the point of where it was a very slow linear process, like they're saying. Every patient was very carefully moved. All equipment was cleaned very thoroughly. We did direct observation of every patient who moved from the main hospital into the new Morris Hyman Pavilion by an infection prevention staff, so they could sit there and sort of give people guidance on what we needed to do to make sure that we were as safe as we could be. And the hospital review of that we did as a multidisciplinary team right up to the day before we opened and right up prior to licensing and after licensing, we walked every single room in this hospital with a lot of help. I had a lot of help from people in doing this, but to make sure that everything was as clean as possible, right down to worrying about dust, everything. So I think that we are going to be in a better position moving forward with private rooms and having new and clean equipment. Surgical site infections, colon surgeries, are something that we have to report to CDC because obviously it's a high-risk procedure for contamination. We have had our 2nd quarter with 0. This is a great reflection of general surgical practice and care for the patient. Same with abdominal hysterectomies. We report those to CMS every quarter, and we've had a long string of 0 infections. It's great. Nursing sensitive indicators, moderate and injury falls are something we look at very seriously for obvious reasons. People falling, any injury such as an abrasion or even a head or hips, things like that, we are really one of the things that they're focusing on mostly. We had 0 of those in the last quarter. So it's probably a reflection of the increased rounds we've done and the nursing supervisor and managers coming in, checking on those patients and making sure that we meet the needs of letting them use the restroom as part of their nightly routine to get ready for bed. Those sort of things are really important so you can kind of get in front of it. The reasons that they typically would try to get up on their own, we're trying to foresee and assist them with so that they don't try to get up on their own and have an injury. Joint Commission National Patient Safety Goals are something we also continue to do well with. Handoff communication is, this is observed from direct observation, and 100% of the cases that we observed, the full handoff communication did occur and was documented. Same with patient identification. You can see that we've had quite a few consecutive quarters here with just one below 100% of making sure that all the patient IDs are verified appropriately and documented. typically when we see something that sustains this high for so long, it's something where we consider, well, do we want to be looking at this? And the recommendation for quality is that, yes, absolutely, you will never be able to stop looking at and observing patient ID, because it's the absolute root cause of how a defect can occur and travel if you don't get it right from the beginning. So this is something we'll continue to do in various departments in the hospital at random and using a sample. Same with procedure timeout done. We have continued to do well here at 99.8% for this quarter. Hand hygiene, obviously we are having some struggles with this. This is our third quarter in a row below the Joint Commission national benchmark, which is 90%. I will tell you that the national average for hand hygiene is closer to 50 to 55%, but Joint Commission is really asking all of us to reach to get a goal of 90%. So we've had a lot of discussions about this. Patient safety team is meeting. We're changing some process with how we look at and observe these, and having a greater group of people trained to go out and observe for hand hygiene. Approaching healthcare workers the moment that you recognize that they are not performing hand hygiene. That would be including physicians also. Dr. Martin's very passionate about taking the data with physicians forward and helping to work with them. And we're working closely through shared governance and nursing and patient safety to see if we can get this above 90%. I spoke to Mrs. Farber about this earlier today, and one of the statements that she wants to be very clear is that we recognize that it's the third quarter in a row. This is not acceptable to us. We don't think it's acceptable, and we will continue to do what we can to get the rates where they need to be. Readmission rates. These are patients who come in, for example, with pneumonia and are readmitted for any reason within 30 days of their discharge. We did see an increase to 21.8%. National average, CMS expects closer to 16.7. So this was 12 out of 55 patients who returned. Of these 12 that we looked at, we had 7 that returned with respiratory issues that were chronic, related to other illnesses that they've had. And the pneumonia on a couple of these patients, they continued to have shortness of breath and came back and were observed for monitoring as an inpatient. So those patients will count in our readmission rate. The Medicare heart attack, in other words known as AMI, is something they continue to look at, and we are above that with a 29.2% rate of readmissions. CMS benchmark is 16%. That would be 7 out of 24 patients. In reviewing these 7 patients, not a single one came back with a cardiac-related illness. So it didn't appear that there were any lessons to be learned related to how we managed the AMI. But however, because it's all-cause readmission, it's going to count for a readmission to that. Heart failure is something that we have focused on a lot it's been about a year since we started the readmissions clinical operations committee chaired by Dr. Halimi and myself. I think we've seen some good success out of this. We're still just, this quarter is like right about benchmark, 21.5. 14 patients out of 65 returning. So one of the things that we have focused on is we have a dedicated staff member right now who is calling and working with patients within a day or two of them being discharged and asking, what do you need help with? Getting to your doctor? Did you make it to your doctor? Are your medications refilled? Talking to family members. We initiated that. She's been doing that for about 8 weeks now, and it's very interesting to hear what happens when they leave and what resources she can facilitate and kind of connect them with things that they need in the community and working with their primary doctors. So we're hoping to develop that role further to see, and then once we get that finalized, we can move on and add other disease states. And what I would recommend at this point probably is pneumonia is what we look at next. And that is it. Thank you.
Thank you. Any questions? Thanks, Mary.
Thank you.
Very much. Okay. Kimberly?
Chris Henry is going to present the financial report.
Tonight we'll be looking at the operational and financial results for Washington Hospital for September. We'll jump right into our operating indicators. Our acute inpatient statistics, these are all, as we've been discussing the last couple of months, being impacted by Medicare's decision to pull total joint knee replacements off of the inpatient-only list and push them to the outpatient setting. So it's impacting the census statistics. So our average daily census for the month was one below budget at 146.2. We had 909 admissions. That was 46 below the budget. Patient days for the month were 29 below the budget at 4,386. We had 155 outpatient observation days. We had budgeted for 123. And our average length of stay for the month was above budget by 0.19 at 4.81 days. Moving into utilization, case mix index, our indication of the level of severity of our patients, shows that we saw more acute patients in the month with a case mix index above budget at 1.545. We'd expected 1.495 in the budget. Deliveries came in 15 below budget in September at 126. We had 360 surgical cases. That was 8 above the budget. That includes our joint replacement cases that came in 15 below budget at 124. Our neurosurgical cases pretty close to budget, just 1 above at 28. Cardiac surgical cases were 7 below the budget at 4. So really our general surgeries drove the variance for the month. Cath lab procedures for the month likewise were below budget at 309. We had budgeted for 353. The majority of that variance was in the cardiac product line. Outpatient visits for the month came in below budget at 6,897. We'd expected 7,185. And our emergency visits continued to be lower than expected by 130 in September at 4,085. And anecdotally, we're hearing that hospitals in the region are experiencing the same lower volumes in their ERs. So it's not limited to us. Quick look at the cath lab activity for the month. Peripheral vascular made up the largest part of the share of the pie at 45% of the procedures. Cardiac followed at 40%, followed by non-vascular interventional radiology procedures that made up 13% of the volume, and neurointerventional radiology at 2%. Looking at productivity, productive FTEs for the month came in 8.1 above the budget at 1,220.1. We had 179 non-productive FTEs in the month. That was 3.2 lower than budget, giving us total FTEs for the month that were 4.9 above budget at 1,399.1. However, our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in 0.4 below budget at 6.61. So staffing was managed pretty well in the month. Moving into the financials, this is our Governmental Accounting Standards Board presentation, which is the presentation we use for our audited financials. Total patient revenue for the month came in a little bit more than $6.7 million below the budget at $154,694,000. However, our contractuals and write-offs for the month came in below budget at 76.65%. We're kind of having the opposite relationship that we had than what we had in August, where our payer mix actually overtook a budget, a positive budget variance. This month, we're having a positive payer mix overtaking a deficit in our gross revenue. Real quick, our contractual allowances for the month came in at 73.4%. We had expected 75.79. That included our government payers, which made up 67.4% of gross revenue versus 71.2%. And our PPO in September was 27.6% versus a budget of 23.5%. And while that may not seem like big shifts, it just illustrates the point that government payers don't pay cost, And when we have a shift in that, it really impacts our financials, both in a positive and negative way, depending on which way it goes. Our provision for bad debt and charity in the month came in about $1.6 million above budget at $5 million, a little over $5 million. We did see private pay at 3.4% versus 2.3% that we expected in the budget. However, overall, our total deductions were almost $7.2 million lower than budget at $118,572,000. So we end up September with net operating revenue $1.563 million above the budget at $37,780,000. Our operating expenses for the month came in pretty darn close to budget at $35,504,000. So we ended up the month of September with an operating bottom line of $2.276 million against a budget of $727,000 for the month. So pretty good variance there. Non-operating income for the month came in a little over $500,000 below budget at $400,000. That included a $393,000 unrealized loss on our investments. And again, with all the gymnastics going on in the financial markets and interest rates going up, we're going to see a little bit more of that, I think. So we ended up September with a total bottom line that was a little bit over $1 million above budget at $2,676,000 from a GASB perspective. So pretty good performance for September. Quick look at our Financial Accounting Standards Board presentation. The gymnastics going on here is FASB likes to see our interest expense up in operating expenses instead of non-operating expenses. And we remove our tax revenue that supports the debt service on our GO bonds and that unrealized loss on our investments. And we end up with an operating bottom line $1,569,000 above the budget at almost $1.8 million. And non-operating, actually a non-operating loss of $169,000, giving us a total bottom line from a FASB perspective, a little over $1.4 million above the budget at $1,630,000. Just a quick note, now that we've opened Morris Hyman Critical Care Pavilion, in November we'll start to see some accounting impacts from that. We'll see depreciation. We'll start depreciating that beautiful building. And we'll see the impact of that on the income statement. Also, the treatment of our interest expense on the borrowings will no longer be capitalized. They'll come to the income statement starting in November. So are there any questions on September?
Questions? No, go ahead. Thank you.
All right, I'd like to present the operational statistics for October. Let's start in terms of gross revenue of $171.1 million for October was above budget by 0.6% and above October of 2017 by 5.2%. As you can see, the inpatient gross revenue of $115.9 million was below budget by 8.9% and 3.5% below budget, below October of 2017. But then if you see the outpatient gross revenue of $55.1 million was above budget by 28.6% and 29.7% above October of 2017. And this really represents that shift that Chris talked about in terms of the joints and the Medicare rules, where now they've shifted from the inpatient side to the outpatient side. All right, moving on to the major drivers of the revenue variance. As you can see, cath lab procedures were above budget by 88, driving cath lab revenue above budget by 4.6 million. Surgical services cases were above budget by 44, driving surgical services revenue 1.1 million above budget. Inpatient days were below budget by 501, driving room and board revenue 2.1 million below budget. And again, the lower level of inpatient activity drove ancillary services revenue below budget by 2.4 million. Key census statistics, average length of stay of 4.61 was below the budget of 4.70. The average length of stay was shorter than the October 2017 average length of stay of 4.68. Outpatient observation days were 43 above budget of 184 days. And the outpatient observation days were also 43 above budget from October 2017. Average daily census of 144 was below the budget of 160.1 by 16.1. And again, a lot of that is driven by joints, and you'll also see deliveries were down again this month. Admissions were 108 below budget at 949. Admissions for the month were 86 below October of 2017's numbers. Again, the shift of joint replacements to the outpatient setting impacted our admissions rates too. Outpatient days of 4,463 were below budget by 501. Patient days for the month were 314 below the October 2017. And again, it's continuing to see the shift of joints to the outpatient setting, so it's not counted on these inpatient days. Surgical trends, surgical cases in October of 402 were above budget by 44. Surgical cases were 65 above the October 2017 data. Inpatient surgeries were 36 below budget at 251 and 18 below the October 2017 volume. Outpatient surgeries were 80 above budget at 151 and 83 above October 2017 volume. And again, outpatient surgeries were above budget by 18, and joints, again, replacements were shifting from the inpatient to the outpatient. Moving on to our surgical activity. General surgical procedures were above budget by 36. General surgical procedures were 43 above October of 2017 volume. Joint replacement surgeries were above budget by 15 and were 22 above the October of 2017 volume. Neurosurgical procedures were below budget by 1, and they were 4 above the October of 2017 volume. Lastly, cardiac surgical procedures were below budget by 6, and they were 4 below the October of 2017 volume. Looking at our cath lab trends, cath lab procedures for October of 427 were 88 above budget and 114 above October 2017 volume. Inpatient cath lab procedures were above budget by 74 at 233 and 88 above the October 2017 volume. Outpatient cath lab procedures were above budget by 14 at 194 and 26 procedures above the same period last year. You can see the breakdown of our cath lab activity. Cardiac procedures were above budget by 48 and 50 above October 2017 volume. Peripheral vascular procedures were above budget by 31 and 39 above the same period last year. Neurointerventional radiology procedures were above budget by 8 and 11 above the October 2017 volume. Lastly, non-vascular interventional radiology procedures were above budget by 1 and 14 above the October 2017 volume. Moving on to deliveries. As mentioned, deliveries for October were 136, which were below budget by 14, and that's 4 below the budget from the same period last year. Non-emergency outpatient visits of 7,945 were above budget by 124. These visits were above the October 2017 volume by 209. X-ray visits were above budget by 8.2%. Cardiac rehab visits were above budget by 10.7%. Rehab visits were above budget by 336.8%. And then lastly, lab visits were below budget by 5.6%. Emergency room visits of 4,047 were below budget by 7.1% and below the same period last year by 7.2% visits. I know, again, anecdotally, we've been hearing that a number of the hospitals in this area are running emergency room volume below. So we're keeping an eye on it. I do know that yesterday and today we've had a large number of people coming to our new emergency room, but we'll see how the trend continues. Productivity indicators, productive FTEs were below budget by 3.1% at 1,246.1. Non-productive FTEs were below budget by 3.6% at 160.2. Total FTEs of 1,406.3 were below budget by 3.1%. So staff did a good job at looking at the productivity of managing FTEs. So total productive FTEs per adjusted occupied bed of 5.87 were below the budget of 6.01 by 2.3%. Total FTEs per adjusted occupied bed of 6.62 were below the budget by 2.4%. Looking at other operational statistics, Washington Outpatient Surgery Center had 531 cases in September. This was 10.4% above the budget of 531 and 9% above the October 2017 volume. Clinic visits of 3,786 were below budget by 1.3% for the month of October and 293 or 7.2% below the October 2017 volume. In terms of the breakdown, Washington Urgent Care was below budget by 165 visits. Nakamura Clinic was below budget by 1 visit. Newark Clinic was above budget by 89 visits. Warm Springs was above budget by 14, and Ohlone Clinic was above budget by 13. The payer mix, the preliminary payer mix information for the month of October was favorable again. Government-sponsored patient revenue made up 70.9% of total gross revenue, which is below the budget of 71.4%. HMO revenue was 2.1% of gross revenue, which is below the budget of 3%. And PPO revenue was 24.8% of gross revenue, which is above the budget of 23.4%, so it was favorable. And then private pay revenue was 2.2% of gross revenue, which, as you can see, is right on budget. Our days cash on hand for October ended at 194 days, up 7 days from last month, so a good indicator for our days cash on hand. Days of gross revenue and accounts receivable were 52, and there were $231,404 in charity care applications pending or approved in October. Those are the statistics for October.
Any questions? Okay, we're going to move on to our action items tonight. The first one is resolution number 1190. Dr. Eden.
Mr. President, I move for adoption of resolution number 1190. This resolution provides for the approval of the Washington Hospital medical staff bylaws and policies as approved by the Washington Hospital medical staff on September 11, 2018. These include 1. Bylaws, 2. Organization manual, 3. Credentialing policy, 4. Focused Professional Practice Evaluation FPPE policy, 5. Ongoing Professional Practice Evaluation OPPE policy, 6. Practitioner Access to Confidential Files policy, 7. Practitioner Health policy, 8. Professional Practice Evaluation policy, 9. Professionalism policy, and 10. Review and concerns related to the utilization policy.
Second.
Thank you. Kimberly, would you like to make a comment?
Dr. Troy, our Chief of Staff, to give just a short overview of the bylaws changes.
Sure, we worked on the bylaws for many, many months with a collaborative group of physicians, as well as Dr. Stewart was on the committee, and we had Al Brooks and other people there. It was quite an effort. We went through everything, and I think we ended up with a very good document at the end that will support behavior and good use of the medical staff.
Well, thank you for your efforts. Okay. Dee?
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Danielson.
Thank you. That motion passes. Next, we're going to consider the compensation for Chief Executive Officer Nancy Farber, and we're going to have Paul Kozachenko come and make a presentation. Go ahead, Paul.
Thank you, Mr. Wallace. As you know, annually, the board considers the Chief Executive Officer's employment agreement. In particular, consideration is given to adjusting base salary and making an award of at-risk compensation. Typically, the review occurs in September, but due to the additional workload in licensing and bringing the new Morris Hyman Critical Care Pavilion online, the review was postponed until today. Tonight, for the board's review, are 3 action items. First, there's a base salary adjustment to be considered based on the board's compensation philosophy, which would mean an adjustment of base compensation around the 65th percentile of the California peer group. Number 2, an award of at-risk compensation, consistent with the board's compensation philosophy, which would not exceed the 75th percentile of the California peer group. And 3, an extension of the term of the employment agreement by 1 year. In your packet are 3 documents related to the agenda item. A memo from me which provides more detailed background information on the process you use in adjusting the Chief Executive Officer's cash compensation. A memo from the Chief Executive Officer which summarizes accomplishments during the prior fiscal year. And a copy of the Integrated Healthcare Strategies Report for 2018. The Integrated Healthcare Strategies report is an independent Integrated Healthcare Strategies is an independent healthcare compensation consultant. The information in the report provides the board with an independent data of base salary and total cash compensation for comparable California healthcare organizations. This report provides the board with information it needs to make decisions about the Chief Executive Officer's base salary and total cash compensation. It is important to note that these documents were posted last Friday on the district's website and are available for public review and download. I'm happy to answer any questions if you have any.
Questions? Anyone? Okay. I guess that Dr. Eapen, would you like to?
Mr. President, I hereby move that the board increase the Chief Executive Officer's base salary by 4%, which is around the 65th percentile of the California peer group, which equals $873,933, and that this adjustment shall be effective as of July 1st, 2018.
Second. Dee?
Excuse me, Dee.
I'm sorry. Pardon?
Would you, I think it'd be appropriate if you opened a public hearing and asked if there's anybody that wanted to speak to it before you took action, and if not, close the public hearing.
Anybody to speak tonight about this? Okay, we'll just continue then.
Okay.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Danielson.
Okay, that motion passes. Next, Dr. Eapen.
Mr. President, I hereby move the board award at-risk compensation to the CEO based on his current compensation philosophy in an amount equal to 25% of base salary, which equals $210,080, which does not exceed the 75th percentile of the California peer group.
Second.
We have a second. Would anybody like to make a comment about this? I think that I would just want to say that given the significant accomplishments by Ms. Farber and her staff, I'm very supportive of this. The financial performance is simply astounding with the GASB, from a GASB perspective, nearly $47 million. The bottom line, from the Financial Accounting Standards Board's perspective, nearly $33 million to the bottom line for the hospital. That is astounding. The opening of the Morris Hyman Critical Care Pavilion on time and on budget. Thank you again, Ed. It was a major accomplishment in the history of this hospital, quite possibly the most significant accomplishment ever. And all of this taking place at the same time that the hospital is recognized nationally for its quality of care. These are significant accomplishments, and so I'm totally in support of the resolution. So with that, pardon?
Does anybody else want to comment?
Would anybody else like to make any comments?
Yes, I would. It's always a sensitive subject to talk about the salary of the chief executive officer. But by any standard, this past year was an absolutely remarkable year for the Washington Township Healthcare District. As Mike has said, the financial performance, the recognition by national agencies, the awards the hospital have received, it almost goes on and on and on as to the wonderful things that have been accomplished. Tonight we applauded when we said we had opened the Morris Hyman Pavilion, and we're all very, very proud of that. It's a wonderful, just tremendous building. But beyond that, the hospital has had a tremendously successful year. I can't imagine not supporting a full at-risk compensation award this year to Ms. Farber.
Thank you.
Well, I fully concur with Mr. Wallace's and Dr. Stewart's comments. In healthcare, results matter, and we've had excellent results in opening the Morris Hyman Critical Care Pavilion on budget and on time, and such a smooth move yesterday. It was wonderful to see all the things that took place to make that happen so safely and effectively. The financial performance, as Mr. Wallace said, is just outstanding. And the quality of care, as you've seen in multiple awards given to the hospital this past year, reflects the quality of care here. So I also fully support the motion and really applaud Ms. Farber and the team of top-notch staff that have been able to deliver to our community this wonderful result.
I think pretty much everything has been well said, and I don't really want to repeat. I pretty much concur with all the statements and pretty much approve the motion.
Thank you, Dr. Eaton.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eapen?
Aye.
Director Danielson?
Okay, that motion passes. Back to you again, Dr. Eaton.
Mr. President, I hereby move that the employment agreement be extended for 1 year for a new term beginning July 1st, 2018 and ending June 30, 2022. And the President of the Board be authorized to execute an amendment to the employment agreement consistent with the actions taken here tonight.
Second?
Any commentary about this?
I think it goes without saying.
Goes without saying? Okay.
Keep a good thing going.
Keep a good thing going. Okay. Dee?
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eapen?
Aye.
Director Danielson?
Okay, that motion passes. We are going to have a closed session, so at this point, we're going to adjourn the open session, and we will convene in the closed session in the room next door. Okay, we're going to reconvene the open session and announce no reportable actions were taken during the closed session. So with that, this meeting is adjourned.